The psychology of poorly designed global health experiences explores kind of how we maybe aren't on point with how we design global health learning opportunities, and kind of the values and principles and foundations of evidence-based interventions for health outcomes, both for populations and individuals. Um, CFHI is convening this space, and we are a nonprofit organization based in the Bay Area with a team that is across 10 countries. Our mission is threefold. We do run global health experiential programs for undergraduate, graduate, and postgraduate students. We also do research on the pedagogy of global health experiential learning, and we provide thought leadership because our goal is really that all programs and all initiatives will kind of seek and move towards the ethical and practical highest good that we can achieve. We've been around for a long time, over 30 years. Dr. Evelyn Jones, who's at Stanford, was our founder. You can see here the countries that our teams are in a variety of different locations. And we also have virtual programming and have students from over 40 countries participating in our programming. Our global team is numerous, over 200 folks. We partner directly with hospitals, clinics, social service organizations, and over 35 sites in 10 countries, and have had more than 15,000 alumni. And we get a lot of accolades, particularly around our nonprofit excellence and transparency. But I still remain, I think, cautiously optimistic and appropriately scrutinizing global health experiences. And when we look at the definition of global health that many of us use, that was published in The Lancet in 2009, the definition is a field of study, research, and practice that place the priority of achieving equity and health for all people. Global health involves multiple disciplines within and beyond the health sciences, a synthesis of population-based prevention and individual-level clinical care, promoting interdisciplinary collaboration, and emphasizing transnational health issues and determinants. In some ways, this definition gives us a target to aim for, and I think it calls us to make sure that we are highlighting and emphasizing actual longitudinal, sustainable interventions that work towards health equity and are multidisciplinary and interdisciplinary. So this is where I'm going to also ask for your help. So when we think about how global health experiences can go off the rails or are poorly designed, some of the things I think of are experiences that the explicit aim is to help people, but instead people are hurt or injured. Experiences that aim to empower communities, but instead they perpetuate power and privilege disequilibrium. Experiences that sideline, go around, or ignore local health systems. Experiences that treat illnesses and are aimed to treat illnesses and bring health, but instead pull patients away from existing health systems and longitudinal care. Experiences that give patients a false sense of security that they are healthy when only a narrow range of conditions are actually being checked for. And the experiences that perpetuate colonial narratives and knowledge inequalities. What are some other poorly designed aspects of global health experiences that you can think of? Feel free to unmute.
Well, I'm thinking about programs where there's inadequate mentorship. You know, a lot of the programs that we do are really not providing health care, but in public health, we're looking at more at health needs, community-based health education rather than providing direct care. So our trainees are rarely involved in managing health, but they're frequently involved in interacting with communities. And you know, and I think you're right on about some of the addressing some of the different perceptions of health in the communities, and having students who are adequately prepared to go into the field and collect data and um, understand the community's points of view, and some of the issues that they're facing is really important.
Yeah, I think that's really helpful to think about. And I think you hit the nail on the head when you say, that the students are adequately prepared to even gather data and get a sense of health practices that are non-clinical. We know that that's not easy either to actually do. Sometimes it seems easy to do surveys or go house to house, but having the rapport, language acquisition, other things make it much more difficult to actually get reliable data. So I appreciate you calling that out, because many people think of clinical activities when they think of poorly designed, but poorly designed can occur in so many contexts, non-clinical and clinical. Other ways that these experiences are poorly designed. I think one thing that's not on here is timelines. I think sometimes I see, Peter Singer said more often there's a compromise between expediency and ethics. And I think sometimes the timelines that we have to do things in are not really congruent with our aims, goals, outcomes that we hope for, and potentially are setting things up to be poorly designed. Any other reflections on how things can be poorly designed in global health experiences? Sometimes mentorship, I think there's been a kind of more contemporary practice of global health, international health in the last 15, 20 years. And folks that are used to practicing or doing things internationally prior to them may have outdated notions of what is appropriate, what's ethical, safe. And when they are mentoring younger people, that can sometimes be a poorly designed situation that's the mentor is driving. And it's difficult for learners to challenge a mentor who's in a higher hierarchy. There's 3 students today that I kind of want to bring into the conversation and dissect a little bit what they did or said, and the notions they gathered. Maybe, Madeline, would you mind reading the quote on the left?
Sure. Dan and Christopher spent much of the summer caring for people in remote villages of Tanzania, where medical professionals seldom are seen. With little supervision from physicians, they traveled village to village, caring for patients suffering from malaria, HIV, chronic pain, and other illnesses. Just being thrust into a situation like that made all of the classes we took that first year very real. You learn quickly that way because you don't have a choice.
Thank you. What are some reflections off the bat of this? This is actually featured in a medical school's magazine, and it was on the cover of it. Are there any reflections or red flags that anyone sees in this excerpt?
Very little mention of the host country communities. It's very much about the checklist of the American students that were going, and how are they trying to build their resumes and not learning.
What else stands out to anybody?
I think the very little supervision and really just absolutely no mention of kind of any integration within like local systems. It's just like doing it on their own.
Hi, Emily. Yeah. Absolutely. And I think,
actually going to
oh, go ahead.
yeah, I was actually going to say the same thing because they went into a foreign land without actually a proper supervision from the physicians. And also the other aspect is if you go in a foreign land to gather information, you need to meet with the locals, you need to meet with people in charge of the place so that they give you information about what kind of systems they have. Because it's not every place where they can welcome you. Other places quite okay, they can welcome you and they can accommodate you, but there are all these cultural differences and then religious differences. So I think so the aspect of no mentorship and people to guide them, I think so it was a big flop.
Excellent, thank you. Any other thoughts on this passage? Who can unmute and read this second one by Roxanne?
I can. So what amazes me too is how holistic is.
Yeah, I blanked out the organization name, just
Okay.
protect the guilty.
Understood. Each day of the blink had a medical, dental, and gynecology component in it. Patients attended a community charla or workshop that educates them about key health practices. We were able to suture a patient whose left hand got caught in between his horse and a fence. The brigaders also provided dental education and fluoride treatment to over 30 children during our pilot day. Truly, blank organization empowered us to provide medical and dental services even in the most remote locations. Yes, there's so much more that needs to be done, but we will do the work one brigade at a time until one day the communities we serve can thrive on their own. Many thanks to Blank organization for giving me an opportunity to go beyond my borders and touch lives in Honduras. It truly was the trip of my lifetime. Hasta luego.
Thank you. So this is an undergraduate student, probably pre-med, but undergraduate in the US education system. So what are some red flags or problems that you see with this passage?
Even if they're a trained hygienist in the US, they're definitely not qualified to be treating patients in Honduras without going through a pretty extensive process, I would imagine.
I mean, both of these passages sound a lot like medical tourism, like they're really more interested in the travel experience and the adventure, and really not thinking that much about the consequences of the healthcare or building sustainability into it.
Both of them too, I think the capabilities of the communities that they're going to seem to be completely invisible to the students. They're not leaving, which means to me, because we run these type of programs, it means that there's the facilitation process of what the students are even, where they're going, what's happening there year round, what ecosystem they're entering into, what is the health system there, seems to be completely invisible to them, and to the extent that they think, number one, that they have to march around village to village handing out medications and treating diseases that I don't think they could actually treat in a short period of time, like HIV, or two, that these brigades need to happen because the communities just can't thrive on their own. So there just really doesn't seem to be any reality-based understanding of what's actually happening. in year round in a sustainable way. Does that resonate with anyone else?
I was just going to say something kind of similar, that it's just dental education and fluoride treatment. Like there's no really indication of that being a priority or any just kind of like justification as why those are the things that they're working on. And so it just underscores, I think, what you said, a disconnect with what's actually the needs and the priorities that are the communities themselves have.
Yeah, Shamuka. I see your hand up. I don't know if we have your audio. Maybe try again. All right, we'll come back to you when we get audio. Or you can use the chat function to type if it's easier. I'd love to hear your thoughts. And then this last one is an email that I actually got from an undergraduate student. It said, I'm trying to establish a long-term and impactful relationship between my school student body and the villages and small towns of South Africa. My school students who have a reputation for being extremely medically driven would be very interested in serving the communities medically, whether it is through patient advocacy, disease illness awareness, or being able to directly participate in minor surgeries and procedures. What are some red flags in this email?
I guess I'll like jump in here, but I think they don't necessarily mean this, but also like in South Africa, there are medical students who are just as driven that already are kind of like living in this environment and truly understand. And again, like they're certified and learning to practice medicine like in the US. And there are like visa necessities to, work. And like if you can't practice medicine in your neighboring state, then why would you practice medicine in like another country without obviously proper permissions?
Yeah, and this is a pre-med student, and it's kind of interesting because oftentimes things like disease illness awareness, patient advocacy can be seen as low risk, although there's certainly risks to trying to do that outside your own cultural context and when you're not fully trained. But the student also then says being able to directly participate in minor surgeries and procedures, which makes me think there's this veiled intent of what they really maybe want to do, which is increasingly scrutinized. When we think about how this happens, today I want to explore kind of some of the psychology behind it. And the definition that I read to you earlier from the Lancet was actually developed at a 2008 meeting of the Consortium of Universities for Global Health, and it was a consensus definition. A lot of people provided input into it, but there was another definition that was put forth at that meeting that didn't make the Lancet, and it was put forth by an East African colleague. And he said that global health is, quote, a concept fabricated by developed countries to explain what is regular practice in developing nations. One of the strong words for me in that alternative definition is the concept of fabricated or fabrication. And so I think as we wade through the psychological aspects of how this happens, thinking about partly there is a fabrication going on helps to frame how this happens. So let's go back to our three student friends. One aspect of it is you'll hear them refer to places in generality. So Dan and Christopher say the remote villages of Tanzania. The student on the right-hand side says that they want long-term and impactful relationships between her school student body and the villages and small towns of South Africa. So this is a common psychological faux pas that happens in poorly designed global health, where you have racial and geographic homogenization. This is when there's a perception that the outgroup, which is often the minoritized group, or geographically somewhere that's far off, is considered to be very similar to each other, to itself, that there's one way that this place is. This is a uniform group, uniform location. Any issue is happening everywhere. And so what happens is, because of outgroup homogenization bias, then places are oversimplified, solutions and engagement with those places is oversimplified. This happens often when we talk about community engaged or community-based participatory research or community engaged work, community-based learning. There's a lot of increasing scrutiny around even using the term community and what that really means. But I want to dive into this homogenization tendency that we have. Have you ever recognized this in yourself or others? How does this resonate with you and what you see in global health or in your own work?
I see this definitely with students, and the use of the othering that can happen even locally. So when, our students who are tutoring students in a local elementary school, talk about working with underserved children when, it's my kid's elementary school. But just because the location is in this suburb of Washington, D.C., that they feel like that looks better on their resume.
Mm-hmm. That's a really helpful example. Other examples of homogenization and how you see that affecting global health or international health, field work experiences?
I mean, for me, it resonated me when you talked about the word community. I think that's a perfect example, because a lot of times it's like we need to engage with the community and engage with just a few folks that also exhibit, for example, a lot of privilege, like within a particular context. And so then folks think that they can check off the box that they've, had this community driven, community led kind of approach, whereas it's not, it just completely discounts the heterogeneity and different power structures and vulnerabilities that might exist that you're not even capturing there.
Yeah, thanks, Emily. Yeah, that's really helpful. And I know, fair trade learning is a movement that's housed by the Collaborative for Community-Based Learning. And one of their rubric items is community leadership. And, the lowest rung on that, the least proficient, the least sophisticated, is that you have one or two points of contact with the community, and those voices represent the community. And it's so incredibly common that we have one or two points of contact who are spokespersons. And from the side of the outsiders, we frame that as working with the community, as responding to community needs, not recognizing that oftentimes the folks we have contact with are often hierarchically higher up. They often speak English, they have email, they often are not from the marginalized or minoritized groups, such as Indigenous groups, women, children, those who have less education. So, but we say, we ask the community, right? We will overgeneralize, we'll homogenize who we spoke with and who is driving our engagement. I really appreciate that example. Other examples of homogenization, you know, Catherine, you mentioned working in our own backyards. I think that there's also this homogenization happens more easily the farther away from our frame of reference we are. So it often can seem like going to Kenya for 2 weeks, you're going to be able to have this huge impact within a short period of time, that if someone asks, well, 10 blocks over where you have Section 8 housing in your own neighborhood, if you went there for 2 weeks, what would your impact be? And students and others, faculty, would have a very different sense of their own agency and their own effectiveness when it's closer to them, because it's less likely to suffer from as much homogenization, because they're seeing that over time and they can see that there's more complexity there.
It's not
Yeah, go ahead.
exactly a homogenization, but the other thing that that comes to mind is that there's a sort of an implicit bias that we as Westerners or Americans are the answer to the health problems of developing countries without drawing on local resources. And that's really what a lot of global health agencies now are drawing on local groups instead of US groups. And some of the students that you mentioned are talking about as if I can go in as a medical student or as an undergraduate student, and I think it's one thing to try to understand the health problems of low and middle income countries, but to feel like you're empowered to go in and do things that you couldn't do in the United States is is just not right.
Absolutely. So let's look at another aspect, kind of psychological aspect of what's going on here. So they are mentioning things like without supervision from physicians, these first-year med students traveled from village to village treating chronic pain, malaria, HIV, that the undergrads were able to suture a patient whose hand got caught. And then the third student is asking to directly participate in minor surgeries and procedures. This experimentation on minoritized or groups that are Black, brown, poor, in servitude in one way or another goes back for the ages. This is Anarcha, and J. Marion Sims, who's considered the father of modern day gynecology, actually did 32 unnecessary gynecological procedures on her. She was a slave. And so as we think about global health organizations, students under the auspices of global health or international health or service, going abroad and trying to do things like treat HIV, chronic pain, things that require expertise, and or suturing and or doing procedures, when that is happening by people who are not expertise in those procedures, who are not expertise in treating HIV in Tanzania, it amounts to experimentation. And this really harks back to some of the darkest days of medicine that exist. And unfortunately, oftentimes outsiders are seen as having expertise even when we don't, because of the way we appear, because we have power and privilege to even be able to walk around and go into villages and open, you know, a bag of medications or bandages. And so really, this is psychologically a manifestation of racism, classism, differential treatment for the poor. I do not think that Dan and Chris would be okay with first-year Kenyan medical students coming to treat their mother's chronic pain, or coming to treat their friend's HIV, or coming to treat their grandmother's urine infection. I do not think that the student on the right, who was actually from Johns Hopkins, would be okay with an undergraduate from, you know, Entebbe University coming over to the US and doing minor procedures on their father. So why is it then that it is okay for these students to say they want to, and to actually go and do these procedures on patients in low and middle income countries? What is the psychology behind that? It's a question for all of you.
Definitely a dehumanization, right, of the patients in this case. Related to the outgroup piece, right? It's very easy to other based on distance and distance from your own experience, and feeding on implicit and explicit biases.
So dehumanization, implicit, explicit bias. What other things are okay? Emily says, I think it's also the idea that, quote, they don't have anything else. So that's not just ignorance, right? Because if the students actually set out to learn what is existing in Tanzania or is existing in Honduras or is existing in South Africa, they would learn about a health system that does exist. It doesn't function perfectly, but neither does ours. So it's not just ignorance. It's really something beyond ignorance. I don't know, what better word would you use or term? How can we capture that?
Like superiority kind of comes to mind, like we know best, which you had a bullet about, you know, colonial narratives and things like that. So I do think it falls within there, but I think there's this default assumption, and also somebody else mentioned this, but you know, if it comes from the West, if it comes from this Eurocentric model, like it's that is going to be superior, and the base knowledge is just kind of better than anything that is going to be found within these contexts. And so, yeah.
Okay, I also think, well, on the other hand, the students maybe had the right intention, which was maybe to help the people. But the major problem in this case is how they went about it. We know that most of the times you would want, when they're getting employment, they want someone with community service, someone that has done voluntary work before. So that being a factor, they thought maybe starting in first year will give them more leverage on employment, because this time employment is very hard everywhere we go. So now they had the right intention, but the procedure that they followed in going to the low and middle income was what was wrong. So it's one thing, again, to have the right motive. It is also another thing to get the right mentorship to do the right thing. So what they really lacked in this case was the right mentorship. If they went to experts and asked them to say, okay, we want to go to these low and middle income countries to go and participate or maybe do some voluntary work, what are the procedures that we can get in order to do these services. So I think so it's an aspect of really mentorship and guidance that was missing in this case.
Mhm. Yeah, and I wonder, where do you think evidence-based medicine fits into this conundrum? Jeffrey, you or anybody?
I think so, seeing that they don't have the right expertise, I don't think so there'll be much evidence that will come from them because it's really biased. The question is, are they using the right proportion? Are they defining the community as it is supposed to be defined? There are a lot of things that are really designed to this. So I don't think so evidence-based medicine will be really defined by the procedure that they follow.
Mhm. Yeah, I mean, seemingly they have no awareness of evidence-based medicine, which is also, part of the problem. Again, why undergrads think that they can, and young, early year clinical medical students think that they can do these things across the world. And I don't think they would necessarily say they can do them, in their own town, I think is a very interesting psychological dynamic, like all the things you guys are talking about. We're going to talk about another dynamic that I think will fit into this, but any other comments on the experimentation component, like how this wanting to do procedures, going and handing out medications that potentially are high risk without follow-up, or saying you're treating things. I guess some of that's hubris, right? Because I really doubt they were treating chronic pain and HIV and malaria wandering without any supervision. But if they, claiming that would be hubris or exaggeration. But this experimentation on those who have less power privilege in a society has happened for a long time in medicine. And seeing this manifestation of global health as such, I think, is an important recognition. Any other thoughts on that? Okay, so I want to bring in two other concepts that I think complement what we're talking about and underlie all three of these scenarios. One is called the oversimplification cause fallacy. So this is a psychological phenomenon that our brains will try, and in order to understand something, our brains will try and simplify the causation of a complex situation. So, and subsequently, we will oversimplify the solution because we've oversimplified the cause. And so some of what, Jeffrey, what you were saying and others is this oversimplification of the cause and this fallacy that our brains tend to oversimplify a situation because we're trying to understand it. So our brains will minimize, will try to package it, will try to come up with a single causation, which then leads us to think that there's a single solution. So students who see the causation of lack of malaria treatment, pain management, HIV treatment in Tanzania as being lack of someone to go there and hand out medications, they then pack their suitcase full of medications and go there and do that because they're not trying to understand the complex results. The other psychological tendency that exists is a deficit orientation. So our brains, when we see something that looks different than what we're used to, that in our minds looks more problematic or looks like there's an issue or things are going poorly or bad compared to what we're used to seeing, our brains will tend to emphasize what's lacking, the problems, the gaps, and what feels wrong to us in places that are differently resourced, culturally incongruent, and contrast with our usual frame of reference. This is only exacerbated by what organizations in global health are telling students and faculty. This is an example of different websites, different organizations advertising global health opportunities in Bolivia. Emily, would you mind unmuting and reading the two?
Sure. So the first one, in Bolivia, people live in extreme poverty, unable to meet their basic needs. You can help by volunteering and providing essential medical care where there is none. Make an impact today, no experience required. And the next one says the plurinational state of Bolivia's healthcare and economic sectors have celebrated many recent victories, including the adoption of universal healthcare in 2019, expeditious and thorough rollout of COVID-19 vaccines and supplies, and significant poverty reduction. Embed yourself in the Bolivian health system to witness the local professionals' provision of care despite resource constraints propelled by a health as a human right framework.
Thank you. So if you're looking for an opportunity in Bolivia and you see website A versus website B, what are the different messages? What's going on here?
The one on the right emphasizes more that we have something to learn from Bolivia's experience.
Yeah, I agree with that. And the one on the left implies you don't really need any experience because there's so many needs that anything is helpful, but that's not always the case.
Mhm.
The one on the left seemed to negate the existence of a Bolivian healthcare system.
Mm-hmm. Yeah, so the poorly designed global health experiences start way upstream of anyone getting on an airplane. And it really starts with the marketing and outreach that's done towards programs or at schools or depending on where this is occurring, you know, and it totally frames like, what is the student doing on this program? What's happening in this place I'm going? Are we focusing on everything that's going wrong, or are we going to talk about, what's going right? That deficit orientation can really be taken advantage of to recruit students to programs. This is a multi-billion-dollar industry in terms of global health volunteering and international volunteering. And so there's a huge financial incentive to minimize what's going on in many places in the world and to position outsiders as saviors. Yeah, and you can see here like a deficit orientation versus an asset orientation. So deficit looking at what's going wrong, assets look at what's going right. I mean, the imagery is very different. So what you take away from the imagery on the left versus the imagery on the right. On the right, that's actually Dr. Vasquez. He's our medical director at the hospital, the pediatric hospital in La Paz, Bolivia. And so he's positioned in the front. Students are in the back. Just the positionality and who's centered as a solution. So this psychological exercise that our brains go through happens depending on how we are marketed to when we decide to do a global health experience, and then the narrative that surrounds that experience. Oftentimes, if we have a narrative that there's nothing going on and you need to go help, when students and faculty land in country, the infrastructure looks extremely different from what they're used to seeing. And so hospitals and clinics that they're used to seeing look like what they look like on the right. If they come from high income settings, look very different. And the things on the left will appear very inadequate, rudimentary, or they'll just be ignored. So the bottom left picture are pictures of community health workers. And these are an essential, cadre of the workforce and providing primary health care and public health surveillance through many countries of the world. And if you didn't know that, you would just walk by and ignore them. And so the narrative and, you know, Jeffrey, what you were saying, how the mentor frames, how the institutions frame these experiences is so essential, because otherwise it will be ignored and the brain will look at what problems exist, because the brain is used to seeing a very different image and a very different reality. And when we focus on what problems exist, we then go to this oversimplification cause fallacy where we're like, oh, these problems exist. It's because they don't have pills. So then we load suitcases up with a bunch of pills, and then we have students set up pharmacies and dole out medications without adequate oversight, without adequate follow-up. And in doing so, there's huge opportunity costs. So the opportunity cost of doing that is that you don't actually learn about the drug supply chain exists. You don't actually learn about an authentic version of reality. You fabricate a reality and you act upon that fabrication, when the goal of global health is actually health equity in a sustainable way. And that means understanding things like the drug supply chain and locally led health and public health initiatives. And so the opportunity costs are that you don't even know this is happening. You don't know that there's a drug supply chain. You don't know what the challenges of that drug supply chain are. You don't know how to advocate or how to act in a way that's actually going to support that sustainable system. So we're trying to move from duffel bag medicine or the oversimplification cause and solution fallacy to a reality-based, authentic understanding of global health. Back to our students, we need them, and all of us need to move really from this idea that we're certain about what's going on to a position of curiosity and recognizing that we don't know what we don't know, and a lot of stuff we don't know is inaccurate for all the reasons we mentioned earlier. Moving from agent to learner and recognizing that a lot of times our sense of agency is based on dehumanization, is based on homogenization, is based on hubris, on superiority, on a greater sense of self and efficacy than we actually have. From exceptionalism to humility, from superiority to inferiority, from simplification to complexity, from deficits to assets, and from critic to admirer. Are there other transitions that you see as necessary to move away from these psychological fallacies that create the fabrication of global health? Do you have any tips for your colleagues on how to do this? Have you in your life ever had that aha moment where you've been able to make some of these shifts? And what helped you?
I think it's the direct interaction with the individuals. That's number one. I think one thing, thinking about what we can do is there's a big trend, right, of virtual global classrooms, and I think giving you the opportunity to interact before getting on a plane with folks in other countries and with other experiences, and having just a conversation about what is your reality and what is your day-to-day, as a stopgap, right, a buffer, I guess, before you're jumping on that, making sure that research happens. But it really is that one-to-one conversation.
Yeah, that humanization. Other things that have worked in your life, anyone's life, to move towards a more authentic understanding of global health.
I mean, I think a really simple exercise, and I do it a lot with my students, something what you were doing, just about just kind of flipping the script. Like, what if it was first year Kenyan doctors, going to treat on your mother, and then they can just really kind of hear how ridiculous it sounds. And especially, as an American, I mean, like, there's just so much fundamentally wrong with our healthcare system, and so many things that other countries do better than us. So whenever I have the opportunity to kind of highlight, like, and this, by the way, this is, if we're talking about maternal mortality, for example, like, very easy segue to talking to some of the issues that the United States has. So just kind of bringing that lens in.
Mhm. Thank you all for joining us today. We'll send out the recording and look forward to seeing you in virtual and real spaces, and just glad that we can all come together to dissect these dynamics.